So you think you have frozen shoulder? Well, let me start by saying that you probably don't. But maybe your therapist, physician, friend, or Dr. Google has said that you might. Well, not everyone with a sore shoulder has this condition. In fact, many of the patients that are referred to me for assessment of their shoulder have other issues. Frozen shoulder is actually a relatively infrequent diagnosis that I see patients present with. I'm orthopedic surgeon Dr. Chris Rayner, owner of Human 2.0, and in this video, I'm going to talk to you about what frozen shoulder is, how you can recognize it, what other conditions might mimic it, and what you can do to avoid or perhaps shorten its duration if you indeed do have it. If this video proves to be useful for you, then like the video and share it with someone who might benefit from this information. And if you want to see more useful tips and techniques like this, then subscribe to the channel. First things first, what the heck is frozen shoulder anyway, and why do people get it? Frozen shoulder syndrome, also known as adhesive capsulitis, is a condition characterized by stiffness, pain, and a significant loss of mobility in the shoulder joint. It occurs when the shoulder joint capsule, or the bag around the shoulder joint that contains lubricating fluid, thickens, tightens, and becomes irritated or inflamed, which limits shoulder movement and makes the shoulder difficult or impossible to move. The exact cause of frozen shoulder is not fully known. However, it often occurs after the shoulder has been immobilized for a period, such as following surgery, injury, or a fracture. But frozen shoulder can occur randomly at other times as well. Other risk factors for this problem include age. It occurs most commonly in people between 40 and 60 years old. Female sex. Women are more often affected, with the most widely cited estimates indicating that women are about 1.4 to 1.8 times more likely to develop frozen shoulder than men. Systemic diseases such as diabetes, thyroid disorders, cardiovascular diseases, and Parkinson's disease. Some people believe that they have frozen shoulder, but there are other shoulder issues that have similar symptoms. How can you know it's frozen shoulder then and not something else? Frozen shoulder is a unique problem that typically progresses through 3 stages, each lasting several months. The freezing stage, where you have increasing pain and a gradual loss of shoulder movement. This stage can last from 2 to 9 months. The frozen stage, where pain may decrease, but stiffness remains and movement is very limited. This stage can last from 4 to 12 months. And finally, the thawing stage. Here, shoulder movement gradually improves and pain continues to decrease. This stage can last from 5 to 24 months. The pain associated with frozen shoulder is often worse at night and can disrupt sleep. One of the key features of frozen shoulder is that it lasts about the same length of time regardless of what is done for treatment. Do nothing, 2 years. Do physio, 2 years. Heaven forbid, have surgery, 2 freaking years. It's definitely not the shoulder problem that you want to have. So it's important to determine if you really have it so that you can decide whether your shoulder can be treated or whether time is the only solution. Diagnosis of frozen shoulder is basically clinical, meaning that we determine its presence based on symptoms and physical examination. Imaging, such as X-rays, a shoulder ultrasound, or an MRI, may be used to rule out other causes of shoulder pain and stiffness, like, for example, arthritis. This is a long way of saying that it is largely a diagnosis of exclusion, meaning if you have shoulder pain investigated by a physician and there are no findings on any of the imaging modalities and you have a mechanical block to shoulder movement that is associated with a pain profile that follows the 3 stages listed above, odds are you have frozen shoulder. But all of these factors must be present at the same time for it to be frozen shoulder. If not, then it is more likely that you have another shoulder problem. Shoulder problems that patients have presented to me with that have been mistakenly labeled frozen shoulder include scapular dyskinesis, biceps tendonitis, rotator cuff tendonitis or tears, slap tears, AC joint arthritis, shoulder arthritis, and occasionally shoulder instability. Each of these problems will have specific symptoms and associated findings on imaging. And unlike frozen shoulder, which presents with a more generalized shoulder pain, each of these other issues typically presents with pain localized to a specific area of the shoulder. The good news is, no matter what condition you have, whether it's frozen shoulder or any of the above listed problems, exercise is always recommended. Unless you've had a trauma and dislocated your shoulder, if you have pain and discomfort, you should be able to start doing mobility work to get things moving better. You cannot make your condition worse with exercise. If you indeed have frozen shoulder, range of motion and stretching exercises are the mainstay of treatment. In rare cases, procedures such as joint distension or arthroscopic surgery may be necessary if conservative treatments fail. In my experience, these are last resort interventions that are generally unlikely to be successful and are not recommended. Most people recover, but full return of shoulder motion, as I mentioned earlier, can take 1 to 3 years, and some people may never regain their full range of motion. But the most important thing to remember is that most of the people who think that they have frozen shoulder don't actually have it. And for those people, there are several things that they can do to address their pain symptoms. The first thing that you can do for most shoulder problems is to restore the optimal position of your scapula, or your shoulder blade. I often tell patients that the scapula is the stage upon which the shoulder acts. For your shoulder to function in a pain-free manner, you have to first ensure that the scapula is in the position that provides the most space for your shoulder to move. Reach your hands as far down to the floor and as far away from your head and neck as possible. And while doing so, turning your palms to face the front. This is the anatomic position and the position from which your shoulders should always start when moving your arms. Several exercises that you can use to strengthen the muscles around the scapula to help with posture and movement include scapular push-ups, dead hangs, and when stronger, active hangs, high rows, prone I's, Y's, T's, and W, and lastly, prone swimmers. The next thing that you can do is to ensure that you are moving your shoulder or your glenohumeral joint independently from your scapula. Although we think of the shoulder as one joint, it is really a complex of 3 joints. The acromioclavicular joint between your collarbone and your shoulder blade, your scapulothoracic joint between your shoulder blade and your upper back, and your glenohumeral joint, which is the actual joint where most of the movement at your shoulder occurs. To check this, stand in front of a mirror and raise one arm at a time in front of you until your hand is over your head. Watch your shoulder and neck in the mirror and notice whether your shoulder raises up at the same time as your arm. If it does, this is a problem. Normally, your shoulder joint, your glenohumeral joint, and your scapula, the scapulothoracic joint, should move independently when you move your arm. However, after surgery or an injury, it is common for these joints to move together, which eventually leads to pain in the neck, shoulder blade, and down the arm. To address this issue, lay on your back, on the floor, or on a bed, and raise your painful arm directly up into the air in front of your face while holding a can or a small weight, 1 to 2 pounds, upward. While keeping your arm straight, allow the weight of the can to gently push your hand overhead towards the floor while pinching your shoulder blades together underneath you. When you reach the maximum extent of your range of motion, hold the can at your farthest point for up to 60 seconds before bending your elbow and lowering the weight. Once you can raise your hand in front of you above shoulder height without elevating your shoulder towards your neck, you can continue to work on maximizing shoulder elevation passively, or without muscle contraction, by standing in front of a wall and placing your hands in front of you against the wall as if you were going to do a push-up against the wall. While keeping your arms straight, and your hands against the wall, bend at the waist as you keep your hands glued to the wall. This will bring your arm overhead without using your shoulder muscles to put it there. Once you reach the maximum extent of your range of motion, you can hold the position at the farthest point for up to 60 seconds before standing upright. After you have restored your shoulder range of motion passively with the exercises already described, you can use shoulder cars or controlled articular rotations to actively work through your shoulder range of motion on a daily basis. You can start these movements while standing in the middle of the room. Remember to keep your shoulder depressed and your scapula retracted while performing these movements. As your shoulder range of motion improves, you can perform your cars with your shoulder closer to the wall so that you are forced to maximize your active range of motion as your shoulder strength improves. Normally, these exercises will help to reduce shoulder pain and improve shoulder range of motion, even if you have one of the shoulder conditions mentioned at the start that aren't frozen shoulder. If you have completed these exercises and you still have shoulder pain, then you should speak with an orthopedic surgeon who specializes in shoulders so that you can have your shoulder properly assessed to determine which condition might be affecting you. Otherwise, as always, that's been a word from Dr. Chris Rayner, not your everyday ortho, where we see one, do one, teach one.